Now we come to the end of this chapter of contraception, and now we will read the permanent methods. So we have read the long acting reversible methods, which were long acting. What did I told you the definition? Anything which you do not need to take a repeat dose within a month, that is long acting. Like DMPA injections we read was long acting, we read implants were long acting, then we read IUCDs are long acting, right? But now we come to something called as permanent methods. Permanent methods are also known by the name limiting methods. They are the limiting methods of contraception because they limit your ability to give rise to further child. So they are limiting your fertility, they are called limiting methods. Though they does fail, they also have a failure rate. Besides having permanent method, a person still can become pregnant, but they are not considered, but that is a failure. As such, they are not irreversible methods of contraception. So they are not long acting. If question is asked on long acting reversible methods, they are non-reversible, right? Okay. Starting with tubal sterilization. So how can we do permanent, how can we provide the permanent contraception? The passage of ovum in females is tube, passage of sperm in males is vast difference. So if we completely close that passage either by occlusion or either we occlude the tube or we completely remove a segment of tube, then we will cause the permanent sterilization. Now starting with the tube, tubal sterilization can be done either by occlusion or by removing a segment of tube. Now first start with tubal sterilization, the timing. When can we, since we have been doing all the contraceptive methods, we are first starting with when can you give it. So here also, when can you sterilize a woman? There are different timings in her lifetime. One is at time of laparotomy, when you are opening abdomen for something else. The most common indication for laparotomy for opening abdomen in a woman is LSCS. So you can very well, when you have LSCS, you are doing LSCS, whole uterus and tubes are in front of you, and that is one time when you can occlude her tube. So consent for this has to be taken before the patient is going for LSCS. So you need a pre-op consent and very well, and you need a written consent, not a verbal consent. You need written consent for this, and during the LSCS laparotomy, you can do a tubal sterilization. Like this. So whole uterus and tubes are available, you can tie it surgically. Other time is postpartum. Once the patient has delivered, then you can also sterilize the tube, but that time you call it mini laparotomy. So this is laparotomy because you are making it approximately 10 centimeter incision on the abdomen. That's what the incision size is in LSCS. Mini lap means when the patient has delivered and your only aim is to remove a small tubal segment and sterilize and tie it, you do not need to make a 10 centimeter incision. You will make a mini laparotomy, the incision is 2 to 3 centimeter. The definition of mini laparotomy is actually less than 5 centimeter incision, but this much is sufficient for tubal sterilization. That is why you call it mini lap. And when can be done mini lap? Mini laparotomy, when it can be done? When the woman has just delivered or any time. We call it interval mini lap. She is not pregnant right now, she does not have any, she has not delivered recently, then can she go for laparotomy? Yes, mini laparotomy. By making a small incision, we can remove the tubes. But where? Abdomen is a pelvic organ during the interval period. Where will we locate it? Then we have to first palpate the uterus, make an incision. I'll tell you the site where the tubes will be more easily accessible. So they both are mini laparotomy, but where you are making the incision will differ. Postpartum, a lady who has just delivered, her uterus is enlarged, right? She has got a large uterus. So where will be the incision will be? When woman has just delivered, her uterus will come to lie at the lower border of umbilicus, that is the postpartum uterine size, and then it keeps on decreasing in size by 1 finger breadth. So where will the mini lap incision will be? It will be below the umbilicus. But when you are doing it in an interval method, means a female who has not been pregnant recently, the uterus will be a pelvic organ. So incision will be the same, the method will be the same, but where will you make the incision? In a suprapubic area. So in mini lap, you are making a suprapubic incision. In postpartum mini lap, you are making an infraumbilical incision. The procedure will be the same. How we open the abdomen, how small the incision is, everything is same. The site will differ. Okay, since here the uterus is pelvic, you will just make just above the pubic symphysis. And if you will make it, I will tell you how you will be able to easily locate the tubes and here infraumbilical. So what do? You have made a small incision. See how small the incision is. And you need somebody to palpate the uterus from below. So once the uterus is fixed from below, because uterus is mobile, if you will try to locate for uterus, it will keep on moving. So somebody need to fix the uterus from below, and then you will, with using one finger, you will palpate some thread-like structure. And this incision is sufficient enough to bring out a loop of the tube. At least 1 centimeter loop of the tube has to be taken out, because you have to tie the ends and cut it. If it is only a small segment and you will tie and cut it, what will happen? The ends will slip out of the suture. You want sufficient ends, you want sufficient length, so that when suture is tied, they don't slip out. So at least 1 centimeter of the segment of tube is taken out and it is surgically tied and cut. That is what is mini lap is. Can you see here during the procedure, can you see what a small incision the surgeon has made? Such a small incision, only the tube has come out. So only the tube has come out using this forceps without damaging the lumen, using this non-tooth forceps, because if it is tooth, we will damage the tube, it will start bleeding. We have to insert it again inside the abdomen, right? So we do not want to damage this structure. So we are using a non-toothed instrument, taking out the tube and ligating it. What is this instrument we are using? It is Babcock's forceps. I don't know why the image has gone. This is nothing but the Babcock's forceps. Babcock forceps is used, it's a forceps which has a lumen in its distal end. This lumen is there so that all the luminal structures can be taken hold of without injuring them, like tubes, like appendix. So Babcock forceps is used for tubectomy. Okay. What are the other methods? So this is about whole laparotomy and mini laparotomy. What about other time? Laproscopically. So you don't need to do any laparotomy, neither major laparotomy nor mini laparotomy. Use a laparoscope, go inside the abdomen using just one incision. So laparoscopic tubal sterilization is done only via using one incision. The laparoscope that is carrying the camera, the same laparoscope has another hole for carrying the instrument. Since now the tubes are not in your hand, you cannot tie it using your hand that you were doing before. So you have to insert something so that the tube can be occluded. So method of doing laparoscopy is different. You are using a laparoscope and going inside the abdomen. So when you are going towards the tube, you need to have certain clips which can be pushed onto the tube. So you need certain clips. There is no surgery which can be done using thread. You need clips so that you can just go and attach that clip to the tube. It is done via single umbilical incision. You go inside via umbilicus. Here only the camera is attached and from here only the instrument is inserted. You do not need another instrument. Okay. And more whenever the camp tubectomy is happening in the camps, then this is the most common method used. Laparoscopic tubal sterilization done under general anesthesia. So mini laparotomy all the time, whenever the incision on stomach is small, you can very well do it using local anesthesia. So laparoscopic sterilization and mini lap both can be done under local anesthesia by using normal sedation. Okay. Another method is hysteroscopy, that abhi tak to you were going from outside and holding the tube. Why not go inside the uterine cavity and occlude it from inside? So this is actually occlusion. You are going to occlude this lumen. This is tubal occlusion done via hysteroscopy. You insert a foreign material made up of steel and titanium inside the tube. Inflammatory reaction will happen and the lumen will occlude. You are not cutting and tying the tube. You are occluding the lumen. So these are the 5 ways by which you can do tubal sterilization. So before going ahead how we do it, let's first see who are the eligible candidates for tubal sterilization. We have to make sure we are giving it to a correct person, because we know it is a permanent method. We were not having any eligibility criteria besides we were just testing the women for certain medical conditions. As such, there was no other eligibility criteria for other contraceptive methods because they were reversible. But this is not reversible. So we have some criteria given by Ministry of Health and Family Welfare Guidelines in 2016. What were they? That client should be ever married. What do we mean by ever married? Means right now this woman can be a widow, she can be a separated, divorced woman, but she has to be married at least once. Unmarried women in our country is not allowed for tubal sterilization. And now don't think that why the unmarried person will come. You don't know people. All kind of people exist. Very well an unmarried girl can come that please sterilize me. And I have seen all these kind of people. So it does happen. So unmarried person is not allowed for permanent methods. Okay, she has to be ever married. Right now she might not be married. That's okay. But at least ever married she should be. Then what should be the age? It is to be done in a girl who is more than 22 and less than 49. Anybody of 18 years married comes to you for sterilization. No. She is very young. She has lot in her lifetime. She might get remarried. Anything can happen. So before 22 years, you will not provide her sterilization. Right? Any other criteria? Yes. The couple should have one child. Many times couple can come and say, we don't want a child. Please sterilize either myself or my female. No. There are many other methods. Give them IUCD, because many times couples are not thinking straight when they come to you. So your idea is not to demotivate them. They can have whatever they want, but do not give them a method which has no reversal. Give them long-acting reversible contraceptive, because you never know they will change your mind. They will change their mind. So anybody who has one child, and not just any child, one child more than 1 year of age, because infant mortality rate is more in India. So until that child has crossed 1 year, we cannot provide sterilization. So what are the criteria? The lady should be married. She should be between 22 to 49, and she should have one child of 1 year age. Then only you are allowed for permanent sterilization. Is this clear? Okay. Yes, obviously there should be sound state of mind for their consent. If not, who will give the consent? The guardian. Always remember, it is the guardian who can give. Guardian can be the parent or the spouse, whosoever, but the term is guardian. Now, techniques of surgery. We saw the different timings when the in the tubal sterilization can be done. So, as the timings are different, the incision size is different, obviously techniques are different. When you are doing tubal ligation during a laparotomy, whole uterus is in front of you, tubes are in front of you, you can tie them in whatever way you want. So there are different surgical techniques to be used during the laparotomy. While you are doing cesarean, what all you can do? So the most commonly done right now is modified pomeroys. Can you see where you have taken a loop, you have picked up a loop, tied it from the base and cut the two ends. That is modified pomeroys. But there are other methods which are not done, but theoretically you have to know. Like Irving's. In Irving's, you have just made a cut and embedded the medial end into the uterus. That is Irving method. Next is Kroner's method, where you are doing the fimbrectomy. Not much preferred, because again it is complete. Even if you want to reverse it, pomeroys can be reversed. The method is irreversible. It is permanent sterilization. If somebody wants reverse, we can try. We cannot assure that yes, your fertility will come back. We can try with pomeroys. The cut ends we have, we can try stitching them. But if somebody has underwent fimbrectomy, absolutely irreversible. We cannot recreate fimbria. So this is Kroner's method. Madlener method, he said, when I have cut the two ends, what will I do? Just like pomeroys, they take a loop and tie it from the base, but instead of cutting, they crush the base. So they crushed the base. So when they did that, they saw that after crushing the base, the tubal lumen was not completely occluded. There was always some segment of lumen which was left, and hence the ectopic pregnancy rates were high. So that was Madlener. One was Parkland. Parkland did nothing. Instead of picking up a loop and then tying the base, this was the tube, they tied it from here and cut in between. That was the simplest. That was Parkland. That one suture here, cut the segment. Whereas pomeroys is take the loop, tie the base and then make a cut. And pomeroys is done most commonly everywhere. But these theoretically other methods you have to know can be done only while doing laparotomy. When you are doing, and what are the suture you are using? In all of these techniques, what is the suture? Plain catgut. Plain catgut. Okay, you have to use plain catgut for doing the self-injectomy. Correct? While doing the mini lap, when you have such a small 2 centimeter incision, only a small loop of tube you are able to see. When you are able to see small loop of tube, Can you just do all these techniques of cutting and tying, embedding in the uterus? You cannot do all this. So when you are doing mini lap, the most commonly procedure which is done is again modified Pomeroy's. You can do few of them. You can take out a lube, crush the base, but the most commonly which is done is modified Pomeroy's, even in mini lap, right? How do you do mini lap? It can be very well done under local anesthesia since the incision is small. So when the patient is lying, yes, if you can see this one, when you make the patient lie and palpate the fundus. Immediately after delivery, the fundus is just below the umbilicus, and if it is an interval method, fundus will be inside the pelvis. So you palpate for the fundus, and wherever you find the uterine fundus, clean it, that area. Now, can you see wherever you have palpated, just if this is the uterus, tubes are always little below the fundus. So if you are able to palpate fundus here, you do not make incision there. You always make incision a little below the fundus. Because when you make incision here, then only you can access the tube. Just on the fundus, the tubes will be far away from you. So wherever you have palpated the fundus, make a small incision below the fundus like this, like here. Okay? Yes. Then give the local anesthesia. So you have given a small incision by infiltrating the skin. Use local anesthesia, which is used is lignocaine. Lignocaine without adrenaline. You do not give adrenaline. Because adrenaline is a vasoconstrictor. What will it do? Many times when you have occluded the tube might be bleeding. But you will not know because of vasoconstriction. And you will just let the tube go inside and you will close it. So adrenaline is not preferred here, because if the tubal bleeding will be there, it will be masked. So lignocaine without adrenaline is used. You infiltrate the skin and the subcutaneous tissue. Then can you see such a small incision is made, and you retract the walls using an Ailey's forceps, which is a tooth forceps. You pull the skin apart. You find the fascia, you dissect the fascia. Like here, you dissect the fascia, and using your finger, you can palpate the thin thread-like structure. As soon as you palpate using this Babcock forceps again, you pull the tube out. You do not use Ailey's forceps, any tooth forceps, because you do not want to damage it. If it will get damaged and once you leave it, it will go inside the tube, inside the abdomen, and it will keep on bleeding. So a non-damaging forceps, Babcock forceps is used. Take out small lumen like this, take it out small lumen like this, and tie it and hold the lumen, tie it and cut it. What are you doing? Modified Pomeroy's. This is the Babcock forceps. Can you see this? End is like this, so that a luminal structure can be taken hold of without damaging it. Right? Okay. So that is the techniques during laparotomy and during mini lap. One thing, till how after delivery, for how many days you can do the sterilization? Like after delivery, within 48 hours we have to introduce IUCD. After 48 hours we said we will not introduce, we will wait for 6 weeks. Same with mini lap, you can do mini laparotomy in a postpartum patient within 7 days. If you can do it within 7 days, it is in the abdomen. After 7 days, it starts going into the pelvis. It is very close to the pelvis and it has high bacterial content that time. So after 7 days, you will not do mini laparotomy. You have to wait for 6 weeks. Just like for IUCD, you were doing whatever you can do within 2 days. And if these 2 days are missed, I told you to wait for 6 weeks. Same with mini lap. Okay. Can laparoscopy be done in postpartum? No. Because if you will insert the laparoscope, the uterus is big and very vascular. So laparoscopy is done only during interval time, not in postpartum. In postpartum, mini lap can be done. That too within 7 days. Is this clear? Okay. Now we come to the laparoscopic technique. So laparoscopy technique, you are making very small incision on the umbilicus and introducing a laparoscope, filling it with the gas. What is the gas for laparoscopy? We will read also in operative gynecology that the CO2 is the gas. You infiltrate it, and through the same laparoscope via which camera is going, it looks like this actually. This is the laparoscope instrument, this is the port for camera, and there is a small port below through which you introduce the instrument. Now you cannot use chromic catgut to tie. It's a laparoscope going inside. Your hand is not going inside. So how will you occlude? You need certain clips or rings which can be inserted inside abdomen via this, and they can be, when they reach the tube, just clip it. So the method again is different. So as we have seen, as the time is different, methods will be different. For laparoscopy, you use different clips, right? This is Filshie clips. So Filshie clips have inner smooth silicone lining, outer side they are made of titanium. So they are titanium clips, inner lining is made of silicone. This is Filshie clip. So this is the instrument. You can introduce it from that umbilical port and is holding this clip, go inside and clip it on the tube. It will get occluded. So this is Filshie clip. Another one, plastic clip, a little softer one, is Halka Kleeman clips. So Halka Kleeman clips are made up of plastic with a spring. So they get very easily occluded. They can very easily go and tightly clip the tube. So they are plastic clips. Other very commonly used method is Fallop rings. So Fallop rings are basically made of silicone again. So they are rings. You hold them and the lumen is so small, but when you are holding them with instrument, the lumen you can stretch it. So it's just when you stretch it, go inside and just hold the loop. You hold a loop of the tube and just release the Fallop ring, and it will just cover this loop. It will just cover the base of the loop like this. This is the tube. You took hold of the loop and you release this ring. So this ring will go and bind the base of that loop. So this is the silicone Fallop ring. Other method you can do in laparoscopy is coagulate it. Use electrocoagulation, hold it with a forceps, pass current and burn it. That is another method. So these are the methods used in laparoscopy. Only problem with using currents is that many times suppose this is the tubal lumen, you are trying to burn it. Whole of the tube doesn't get burned. Some kind of fistula still remains. And whenever pregnancy happens through that fistula, it is always ectopic. So it has a higher chance of pregnancy, and that too ectopic pregnancy. That is the side effect. But one thing is that if the tube is thick, it is dilated, it is inflamed due to salpingitis, then the use of these rings and clips is very tough, because these clips are small clips for a defined tubal lumen. If the tube is thick, you try to put a clip onto it, the clip might dislodge. So in such a tube, only the bipolar current will help. So that is a good thing of current, that they can be used in any thickness of tube, right? Failure of permanent method, yes, they can happen. The Pearl index is 0.5 of tubal sterilization. Pearl index is 0.5. Here only I will tell you the Pearl index of vasectomy is 0.1. So they do fail. But you know what is the most common cause of failure? The woman was actually pregnant already. That is the most common cause. When you did the tubectomy, she was already pregnant. So you have to be very sure that she is not pregnant when you are doing a tubal sterilization. Then pregnancy, if pregnancy does happen after sterilization, there are very high chances that 1/3 of them will be ectopic. Because you have sterilized, you have cut the tube, if somehow some sperm has passed onto it, it is very tough for embryo to come into the cavity. So 33% time they are ectopic. Then what method has the least failure rate? Unipolar coagulation and modified Pomeroy's have the least failure rate. So if you are doing laparoscopy, then unipolar coagulation has least failure rate. If you are doing a laparotomy, if you are doing laparoscopy, if you are doing laparotomy, then modified Pomeroy's has the least failure rate. Okay? High failure rate is of Hulka clips. So they are plastic clips, isn't it? So they get loosened with time. That is why Filshie clips were made. Filshie clips were of titanium from outside, so that the tightness is maintained. So Hulka clips and bipolar coagulation have the highest failure rate, right? Another method was hysteroscopy, where you were not cutting the tube, you are occluding it from inside. Good thing about hysteroscopy is it can be very well done in OPD within 10 minutes under just sedation. It's a very quickly done procedure. You go inside using a hysteroscope, insert this Assure. So what do we use is, Assure is a micro insert which is made up of a soft stainless steel from inside. Soft stainless steel from inside, and outside it is nickel titanium alloy. So that's what it is made of. What do? Hysteroscopically, you go inside and you insert it inside the tubal lumen. So it is very soft and thin, because see, imagine tube is the diameter of tube is very small. So it can be very easily perforated. So that is why it's a soft tube which is inserted inside. And how do you know that I have inserted it to the correct depth? Whenever it is completely inserted, 3 to 4 loops of this spring coil will always be visible inside uterine cavity. If more than this is visible, it means you have not gone sufficiently inside the tube. And if none of the loops are visible, it means you have perforated and you have gone out somewhere else, right? So this is the hysteroscopic method where you use Assure micro insert to occlude the tube. Since you are occluding it, an inflammation occurs in the tubal lumen and it gets completely closed. It's a completely irreversible method. No doubt all are irreversible, but there are still chances of failure. Here failure has never been reported up till now. It has just been introduced in 2000, just approved by FDA in 2002, sorry. In 2002 it was FDA approved. So no pregnancy rates have been approved, has been seen. Besides, if you want reversal, which we will just study, if somebody has got tubectomy, now she wants reversal. So can we reverse it? Yes. Though we are not very sure that it will completely reverse her tubal cavity, it will reverse her pregnancy rate to the same level. We cannot assure, but we can try. But in hysteroscopic method, reversal is absolutely not possible. You have destroyed the lumen, you cannot remake the lumen. One thing. Also, the inflammation and occlusion take time. So immediately after inserting Assure, it doesn't mean the woman is sterile now. It takes 3 months for women to occlude completely the tube. So after 3 months, you will check the tubal patency by doing HSG, and then only you can say whether is woman completely sterile or not. Not sterile, sterilized or not, right? So if on doing HSG you saw that there is no peritoneal spill of the dye, then you can say that now you are completely sterilized. Okay? So after how long you will do it? After 3 months. This is about Assure, hysteroscopic method. So do you see ki there are different methods of doing the tubal sterilization, and the time when you are doing it is also different. Now we come to the sterilization reversal. Many times it's happened that patient had a kid, the couple had the kid, but somehow via some accident, maybe they lost the kid and they want again to be pregnant. So in that case, they come for sterilization reversal. One option is IVF, offer them IVF. But IVF is costly and it is one-time thing. If she wants to become pregnant again, she has to go for IVF again. Whereas if you do tuboplasty, means surgery of the tube, it is less costly, and once if it is successful, you can become pregnant anytime. So it is not a one-time thing. So many times patient opt for tuboplasty. The success rate for getting pregnant is same for both. But the success rate for a live delivery, for a live birth, is more for IVF. What is the difference? Pregnancy does not mean that it will always end up in live birth. So rate of becoming pregnant in both the procedures is same, almost 60 to 70%. But many times the pregnancy after tuboplasty is actually ectopic. So live birth rate is not same and it is more in IVF. Because UPT positive doesn't mean you will have a baby after 9 months. It can be ectopic also, and which is there in tubal surgery. Is this clear? Okay. So what will decide? So definitely we have just discussed it's an irreversible procedure. Then how can we say it can be reversed? Yes, we can, though it is an irreversible procedure, but you can reverse it using a surgery. So without doing anything, without doing the surgery, it is a permanent method. But you can reverse it using a surgery, and there are certain factors which will decide the success of that surgery. What are those factors? So it depends on the type of the surgical procedure. It means if you use the Pomeroy's technique, if you use these surgical threads, then the reversal is easy compared to if you have used electrocoagulation. If you have burnt it, then the reversal are less. Then condition of the tube. If the condition of the remaining tube, it is scarred, it is inflamed, reversal is bad. If it is healthy, reversal is good. Remaining length of the tube. How much tubal length is remaining? If more than 4 centimeter tubal length is remaining with you, the chances of reversal are good. Then the site of anastomosis. The best anastomotic site is isthmo-isthmic. Why? Because if you have tied isthmus here, you have one isthmus here, then the reversal of these two isthmic segments is easy. So isthmo-isthmic site is best for reversal. And obviously the surgical competency. This is the best thing. How good the surgeon is. So all these will decide the success of reversal procedure. What will not play a role here is the time. The time when you decide for reversal and the time you got the tubectomy. This duration will not decide the success rate. So from tubectomy to the decision of reversal, if this time is more, it doesn't matter, it will not affect the reversal rate. But it does matter in vasectomy. That's why I'm telling you here. In vasectomy, if you are doing a reversal, you have to ask when did the vasectomy was done. If it was done 10 years back, you have to tell the reversal rates are very low. But it is not true in tubectomy. Why in vasectomy? Because men tend to form the anti-sperm antibodies. And if the more time has been passed, more antibodies, there are more chances that as soon as if you will do the reversal, more antibodies will be formed. That is why the failure rates are high. Okay, so it is time dependent, whereas tubectomy reversal is not time dependent. Learning about vasectomy, vasectomy is another permanent method. It is more efficacious. Efficacy is more. Its Pearl index is 0.1, whereas tubectomy Pearl index was 0.5. It is easy to perform. It is quick and easy. It has less complications compared to tubectomy. Then reversal rates are very good. If you do the reversal, 90% will become fertile again. But still it is not as commonly done as the tubectomy. Tubectomy is more commonly performed, not vasectomy. Right? So what do you do in vasectomy? So this is the internal genitalia of a male. So how does sperm travel? After being synthesized in the testes by the Sertoli cells, they get stored in the epididymis. From there, they travel into the vas deferens. They go up, they meet the seminal fluid. So this is your seminal vesicle. After meeting seminal vesicle, the next duct which you get here is ejaculatory duct. So vas deferens, after meeting with seminal fluid, it becomes ejaculatory duct, and ejaculatory duct finally drains into the urethra, which is the exit channel for urine and semen both. So which segment do we ligate? Here we ligate the vas deferens, and hence the name is vasectomy. Now vasectomy can be done via two ways. In initial years we used to do scalpel vasectomy, but now what we do is non-scalpel vasectomy, NSV. What is the difference? First of all, both are done under local anesthesia. The vas deferens is very easily palpable in the scrotum. So previously we used to give 1 to 2 centimeter incision under local anesthesia on the scrotal skin, and then we used to palpate the vas, very easily palpable, take a loop of it out and used to ligate again and cut it. But then it was seen that the scrotal skin is very stretchable. You do not need to give an incision. Simple hole. Just make a simple hole and just stretch it. Insert an artery forceps, stretch it. It will become of sufficient lumen that you can bring out a vas segment. So here incision was given, and that is why after procedure you had to stitch it. So when you are giving an incision, you are stitching it, obviously it's more invasive, recovery is late, and there are chances of hematoma. But when you are making a puncture, and with one puncture hole, it is so mobile skin that both the vas can be ligated with one puncture hole. But you do not need to stitch. Once the vas have been ligated, leave it. It will heal itself. So no stitch needed. That is why there is very fast recovery and no hematoma risk. That is the only difference. But on the inside, you are doing the same procedure. You are cutting and ligating the vas. Right? So they both are done under local anesthesia. The success rate is same for both because the procedure inside is same. But again, once you have done the vasectomy, there are certain sperms in the system distal to it. In the remaining ejaculatory duct, urethra and the vas, there are certain sperms there. So they all need to be washed out. The washing out takes at least 20 ejaculates. 20 ejaculates or 3 months. So after 3 months, you do a semen analysis twice. and when the semen analysis shows no sperm, means azoospermia, then only you declare that man that you are now sterilized. Got it? So, just like hysteroscopy, in hysteroscopic method, you were after 3 months checking for tubal cavity, checking for tubal patency. Here also, after 3 months, you will check the semen analysis to make sure that all the sperms have washed out. Right? Now, we have come to the end. We have discussed everything. There is something called as healthy timing and spacing in pregnancy given by Ministry of Health and Family Welfare. So, these are not the guidelines which are strict to be followed, but they describe what we considered healthy timing. If a woman comes to me that I have one child, how much should I wait before giving birth to another child? There has to be some healthy spacing. So, how does government decide healthy spacing? They say after having one child, wait for at least 24 months for another child, wait for at least 2 years. So, that is considered a healthy spacing. After having an abortion, wait for 6 months. So, after having delivery, wait for 2 years. After having abortion, wait for 6 months. And overall, wait to become pregnant until you are 18 years of age. So, do not become pregnant until 18 years. So, these 3 are the healthy timing and spacing of pregnancy. So, this is all about contraception, and that's it. Bye-bye.